So your stroke patient has come back from CAT scan. We verified that the patient's not having a hemorrhagic event. We've gone through our exclusion criteria for fibrinolytic therapy, and everything's groovy except your patient is hypertensive. No worries, relative contraindication, we can fix that. Now the literature cites two medications for this. One is Labetalol, and the other one is Cardene, Nicardipine, or Cardene. First, Labetalol. Now, if you read in the books, it classifies it as a beta blocker. A lot of drugs are beta blockers. You must look up the pharmacology, the mechanism of action of that particular beta blocker, because they're not all the same. All of them are a little bit different, and they have a little different pharmacology, and the mechanism of action is different. Labetalol, first, is a very selective alpha-1 blocker. I thought you said it was a beta blocker. It is a beta blocker, but it's also an alpha blocker. So it's going to cause some peripheral vasodilation, and that's going to bring their pressure down. In addition, it's a non-selective beta-1 and beta-2 antagonist. So it is a beta blocker. It's going to reduce the contractility of the heart, reduce those contractions, and help bring that pressure down, control their high blood pressure. Great drug. I've used it. A lot of applications for Labetalol. Now, the dosing for Labetalol, 10 to 20 milligrams over 1 to 2 minutes, and you can repeat this one time in about 15 minutes. It's a great drug. You can start a Labetalol drip, and a Labetalol drip is anywhere between 2 and 8 milligrams per minute. Now, when you're titrating beta blockers or any vasoactive medication, go slow. Take your time. What you don't want to do is start going back and forth with the drug. All of a sudden you turn it up, you tank their pressure, you turn it off, their pressure comes back up. Slowly monitor your patient. If you have an art line, even better, but in an acute stroke you probably won't. So serial non-invasive blood pressures, like every 10 minutes. The other medication is Cardene. Cardene is a calcium channel blocker, completely different mechanism of action. Now the dosing for Cardene, it's an infusion, 5 to 15 milligrams per hour. And you're gonna titrate it every 5 to 15 minutes at 2.5 milligram increments, okay? 5 to 15 milligrams per hour, titrated 2.5 milligrams per titration. Now you're probably thinking, boy, that sounds familiar. Where have I heard that dosing before? Well, you probably don't use Cardene all the time, but you probably use Cardizem all the time. And the dosing for Cardizem is 5 to 15 milligrams per hour, but the titration increment is 5 milligrams. So about every 15 minutes, 5 to 15 minutes, you're gonna bump it up 5 milligrams. And that's how I remember it. It's the same as Cardizem, except the dosing titration amount drops by half. Now, one drug's a beta blocker, the other one's a calcium channel blocker. What do you use? Well, here's one rule. You will never, ever administer beta blockers to an asthmatic. You can throw them into an asthma attack. You can cause more problems. So any patient with asthma or underlying pulmonary disease, most physicians aren't going to give them a beta blocker. That's okay, we can use Cardene. It's not a beta blocker, it's a calcium channel blocker, and it's safer for asthmatics. So this has just been a quick review of two medications they recommend to reduce blood pressure in the acute stroke. I'm Mark, thanks for watching, and I'll see you in the next video.